Somewhere in a hospital in the United States right now, a physician is dictating notes while an algorithm transcribes them, edits them, and files them automatically into a patient's record. Down the hall, another algorithm is scanning a chest X-ray before the radiologist opens the file. In the billing department, software is assigning diagnostic codes to procedures that happened an hour ago. None of this is experimental. None of it is pilot stage. All of it is live, operational, and woven into the daily functioning of nearly every major hospital system in the country. The American Hospital Association, which represents close to 5,000 member hospitals and health systems, confirmed in 2026 that its members have already deployed AI tools ranging from ambient listening technologies for clinical documentation to algorithms supporting clinicians in the interpretation of medical images. That is not a projection. That is the current state of American medicine, and yet the patients moving through those hospitals, receiving those diagnoses, filling those prescriptions, being assigned those treatment pathways, have no knowledge that algorithmic systems played any role in their care. There is no disclosure requirement. There is no standardized consent process. There is no federal law mandating that a patient be told when an AI system influenced a decision about their body. The pharmaceutical industry operates under a framework that took decades to build. A new drug requires clinical trials, randomized and controlled, involving thousands of patients across multiple phases, reviewed by the Food and Drug Administration before a single milligram reaches a patient. The standards are imperfect, but they exist. For hospital AI systems making decisions of equivalent consequence, those standards do not exist in the same form. Policy frameworks governing their use were still being developed through government requests for information as recently as 2026. What is unfolding inside hospitals is not a cautious, deliberate adoption of a new clinical tool. It is a full-scale deployment of decision-influencing systems driven by financial pressure and administrative crisis, moving faster than the regulatory architecture designed to protect patients. The deployment began quietly through the administrative layer. Hospitals drowning in paperwork turned to AI, not because of a clinical mandate, but because the alternative was losing physicians to burnout at a rate the system could not sustain. The documentation burden on a practicing physician in the United States had, by the mid-2020s, become a primary driver of workforce attrition. Doctors were spending more hours charting than treating. Something had to give. Ambient listening technology was the first large-scale answer. These are AI systems that sit passively in an exam room, recording a physician-patient encounter, then generate a structured clinical note automatically. The physician reviews it, approves it, and moves to the next patient. Companies including Microsoft-backed Nuance and a cluster of competitors position these tools as the solution to what physicians called the documentation crisis. Hospitals adopted them at scale. Simultaneously, AI entered the imaging pipeline. Algorithms trained on millions of annotated medical images began functioning as a first-pass reader, flagging anomalies in chest X-rays, screening mammograms, CT scans, and retinal photographs before a radiologist reviewed the file. The FDA had cleared more than 500 AI-enabled medical devices by 2023, the majority concentrated in radiology. Scheduling and triage followed. Chatbot systems began handling patient intake, appointment routing, and symptom assessment. Some hospital systems deployed AI to predict which patients were at elevated risk of readmission within 30 days of discharge, allowing care coordinators to intervene before a return visit became an emergency. Then came the billing layer, which would prove to be one of the most consequential and least scrutinized deployments of all. AI coding tools analyze clinical documentation and assign the diagnostic and procedural codes that determine how much a hospital gets paid. Mercy Health, a regional health system operating across Wisconsin and Illinois, reported a 5.1% revenue increase After implementing one such system, the improvement was real and measurable. The clinical implications of delegating code assignment to an algorithm with revenue optimization as the primary benchmark received far less attention. Across all these categories, the adoption was shaped by a single underlying pressure: the financial and operational survival of institutions that could no longer staff their way out of administrative collapse. AI was adopted as a practical necessity. Whether it was safe came second. The word decision is contested in conversations about hospital AI. Administrators and vendors are careful to describe these systems as decision support, tools that assist clinicians rather than replace them. The clinical and legal framing matters, but the operational reality is more complicated. Prior authorization is one of the clearest examples of where algorithmic output functions as a decision regardless of how it is classified. Prior authorization is the process by which a health insurer approves or denies a treatment, procedure, or medication before it is delivered. It is a gatekeeper mechanism, and it determines whether a patient receives care. Insurance companies began deploying AI systems to process prior authorization requests at scale, evaluating clinical criteria, cross-referencing policy rules, and generating approvals or denials faster than any human reviewer could. The volume explains the appeal. A large insurer might process hundreds of thousands of prior authorization requests per month. Automating that process at any significant percentage yields enormous cost savings, but the errors embedded in those systems do not scale at the same rate as the efficiency gains. A 2023 Senate Finance Committee investigation found that major insurers were using AI to deny Medicare Advantage claims at rates that internal audits later found to be unjustified. The algorithm was not a neutral processor. It had a disposition. On the provider side of the same transaction, a separate and uncoordinated set of AI systems was running. Some hospitals deployed AI tools specifically designed to accelerate prior authorization approvals, generating clinical justifications, assembling documentation packages, and submitting requests in formats designed to satisfy insurer criteria. The result? In some operational scenarios documented by MedCity News in 2026, was two AI systems on opposite sides of the same patient's care request, one built to approve and one built to deny, with no mechanism for coordination and no human in the loop at the moment of conflict. A patient needs an MRI. The provider-side AI submits a prior authorization request with supporting clinical documentation. The payer-side AI processes it against policy criteria and issues a denial. Neither system knows the other exists. The patient waits. Medical imaging presented a different category of consequence. Algorithms functioning as first-pass readers in radiology pipelines were making preliminary assessments of pathology, flagging what looks like a pulmonary nodule, flagging what looks like a fracture, flagging what does not look like anything concerning. The radiologist was supposed to serve as the final check. In practice, cognitive science research on human decision-making consistently shows that when a person is presented with a prior assessment, even one they know to be machine-generated, it anchors their evaluation. The algorithm's output shapes the physician's output, even when the physician believes they are reviewing independently. Triage algorithms operating in emergency departments were assigning acuity scores, numerical rankings of how urgently a patient needs to be seen, that directly controlled the sequence and speed of care. The algorithm's score was not a suggestion. It determined who waited and for how long. These are not systems providing information to a human decision-maker operating in a vacuum. They are systems embedded in workflows where their outputs carry institutional authority. Drug development in the United States follows a defined sequence. Preclinical research, Phase 1, safety trials in small human cohorts, Phase 2 efficacy trials in larger populations, Phase 3 randomized controlled trials involving thousands of patients, FDA review, and conditional post-market surveillance. The process takes an average of 10 to 15 years and costs billions of dollars per approved compound. The framework is neither perfect nor free of commercial distortion, but its core architecture rests on a principle. A medical intervention must demonstrate safety and efficacy in a controlled setting before reaching the general patient population. Hospital AI systems do not move through that architecture. The FDA regulates a subset of AI-enabled medical devices, primarily software that qualifies as a medical device under existing law, such as imaging analysis tools that produce clinical outputs. By 2023, the FDA had cleared more than 500 such devices, but the clearance pathway most commonly used, known as 510(k), allows a device to reach the market by demonstrating substantial equivalence to a previously cleared device, without requiring clinical trial data proving the new device is safe and effective on its own terms. AI systems used for billing, documentation, prior authorization processing, scheduling, and administrative decision-making fall largely outside FDA jurisdiction. They are not classified as medical devices, they are software products. Their deployment requires no regulatory review, no clinical validation submitted to a federal body, and no standardized post-market monitoring requirement. The practical consequence is that a hospital can purchase and deploy an AI system that influences patient care decisions, directly or indirectly, without any requirement to demonstrate that the system performs safely across the demographic range of its patient population, without any requirement to disclose the system's error rate to patients, and without any obligation to report adverse outcomes to a centralized registry. ECRI, an independent organization dedicated to patient safety research, placed AI fifth on its annual list of the top 10 health technology hazards in 2024. The organization's president stated plainly, "We don't have the right mechanisms in place to make sure it is safe." That is not an academic observation. ECRI evaluates medical technology against the specific question of whether it harms patients. In 2024, AI ranked above surgical energy devices and infusion pump errors on that hazard list. Federal policy had not caught up. As of 2026, government agencies were still issuing requests for information, preliminary bureaucratic steps toward potential future rulemaking on how AI in healthcare should be governed. Meanwhile, the systems were already operating on millions of patients. The gap between deployment velocity and regulatory readiness is not a new problem in American healthcare. Electronic health records were adopted at massive scale before interoperability standards were established, creating fragmentation that cost billions of dollars and years of clinical friction to partially resolve. The AI deployment curve is steeper, the system more opaque, and the potential for harm distributed across a wider range of clinical functions. The adversarial architecture of American healthcare, in which insurers and providers operate as financially opposed parties, predates AI by decades. AI did not create that conflict. It automated and accelerated it, and in doing so, turned structural friction into a source of direct patient harm. The prior authorization collision described by MedCity News in 2026 was not an isolated scenario. It reflected a systemic pattern. Provider organizations and payer organizations deploying AI independently, optimizing for their own interests with no shared data standards, no coordination protocols, and no regulatory requirement for interoperability. When two algorithms disagree about a patient's care, there is no automatic escalation pathway to a human reviewer. The denial stands until someone files an appeal, which requires time, documentation, and persistence that not every patient or physician can sustain. The insurance industry's use of AI for claims denial attracted specific congressional attention after investigative reporting in 2023 revealed that United Health Group's algorithm known as NH-Predict was generating post-acute care denials for Medicare Advantage patients at a rate that internal data showed was medically unjustified. In a significant percentage of cases, patients who had been approved for inpatient rehabilitation after strokes or surgeries were being denied continued coverage based on algorithmic assessments that contradicted the judgment of their treating physicians. Lawsuits followed. Senate investigations followed. The algorithm remained in use during the period of scrutiny. Imaging AI produced its own documented failure modes. A 2021 study published in Nature Medicine examined the performance of a dermatology AI system trained predominantly on images of lighter-skinned patients. The system's accuracy dropped significantly when applied to patients with darker skin tones, a predictable consequence of a training data set that did not represent the population the system would eventually encounter. The pattern was not specific to dermatology. Multiple studies examining radiology AI tools found performance disparities across racial and ethnic groups, with consistently lower accuracy in populations underrepresented in the training data. The ambient documentation systems introduced their own category of error. These tools transcribed physician-patient encounters and generated clinical notes, but they generated notes based on what was said, not necessarily on what was clinically accurate. If a physician misspoke, if a patient used imprecise language, if a diagnosis was still provisional, the AI produced a note reflecting the spoken word rather than the clinical reality. Those notes entered the permanent medical record. Downstream physicians reading those records made decisions based on them. The error propagated invisibly through the system. Triage algorithms in emergency settings carried stakes that were immediately visible. A 2022 study published in JAMA Internal Medicine found that a widely used sepsis prediction algorithm deployed across hundreds of hospitals generated false alerts at a rate that caused alert fatigue among nursing staff, a condition in which clinicians become desensitized to warnings because so many warnings are inaccurate. Alert fatigue is a known, quantified contributor to missed diagnoses. The algorithm designed to catch a life-threatening condition was, under real-world conditions, making it harder to catch. None of these failures occurred because the systems were conceived maliciously. They occurred because the systems were deployed at scale, under financial pressure, without the validation infrastructure that would have identified these failure modes before they reached patients. The physicians who welcomed AI into their workflows did not do so naively. They did so because the alternative had already been tried, and it had not worked. By 2024, physician burnout in the United States had reached levels that the American Medical Association described as a public health crisis. Survey data from that year showed that more than 50% of physicians reported experiencing burnout symptoms, with administrative burden identified as the primary driver ahead of patient volume, compensation concerns, or clinical complexity. Physicians were spending, on average, nearly 2 hours on electronic health record tasks for every hour of direct patient contact. The documentation system was consuming the workforce. Against that backdrop, ambient AI documentation tools were not received as an imposition. They were received as relief. Physicians who had spent decades dictating notes after 10-hour shifts reported in multiple published surveys that AI scribing tools returned meaningful time to clinical work and reduced the sense of administrative suffocation that had made medicine feel unsustainable. The NHS AI Physiotherapy Clinic in Cambridgeshire operating with technology from Flock Health, reduced musculoskeletal waiting times by 44% and back pain waiting lists by 55% during a 12-week trial in 2025. The clinic saved 856 clinician hours per month. Patients reported outcomes equal to or better than traditional care. NHS England moved to expand the rollout. Those results were real. The physicians and administrators who cited them were not fabricating enthusiasm. The efficiency gains were documented, the patient outcomes measurable, and the workforce relief tangible. For health systems operating under structural staffing shortages and historic levels of administrative debt, AI represented a functional path out of a documented crisis. The disagreement was not about whether AI could produce benefits, it was about whether the deployment of systems with those benefits had been validated sufficiently to justify the risks being taken with patients who had not consented to participate in what was, functionally, a live experiment. ACRE's position was direct. The Patient Safety Organization's 2024 hazard assessment did not argue that AI should be removed from hospitals. It argued that the mechanisms for ensuring safety had not been established before widespread deployment had already occurred. The sequencing was wrong. Hospitals had adopted first and were assessing safety second. Some physicians pushed the argument further. The financial structure of AI adoption raised questions that were distinct from patient safety questions. AI coding tools like the one that generated a 5.1% revenue increase for Mercy Health were not designed primarily to improve clinical outcomes. They were designed to improve revenue capture. The fact that they worked as financial instruments did not make them clinically neutral. A system optimized to find billing codes that maximize reimbursement was also a system capable of upcoding, assigning higher severity codes to encounters than the clinical documentation strictly supported. Whether intentional or emergent, the incentive structure of revenue-focused AI pointed in a direction that did not necessarily align with patient welfare. The physicians